Hey everybody out there listening. On behalf of the Quality Assurance Quality Improvement team here at Allegiance Mobile Health, my name is Adam Baer and this is your Medic Minute. In today's Medic Minute, we will discuss the 10 steps for ECG rhythm interpretation. As paramedics, one of the most important skills we need to know is how to properly break down an ECG so that we can assess for potential life-threatening cardiac problems that our patients may be experiencing. The content for today's Medic Minute presentation can be found in an article on EMS1 by Kevin Grange titled ECG Interpretation, 10 Steps for Rhythm Identification. A link to the article can be found below. So when looking at an ECG, the first thing we will look for is if the rhythm is regular or irregular. We can quickly do this by analyzing our QRS complexes. Do they march out evenly? Or is there variation in the spacing between complexes? Next, we will calculate the heart rate. For this, we will not only look at the monitor, but we will also feel for a radial pulse to confirm if the number displayed on our screen is in fact accurate. Remember that for some patients, such as those with atrial fibrillation, the heart rate shown on the monitor can be significantly different from what is felt radially or heard apically. We can also calculate the rate of a normal rhythm by counting each large box. As each large box passes without a QRS complex, the rate is lower. In this example, you can see that the second QRS occurs at the 100 mark to show that this patient has a heart rate of 100 beats per minute. The third step in rhythm identification is to find the P waves. The P wave represents atrial depolarization. Ask yourself, are P waves present? Is there a P wave before every QRS segment? Are they upright when we look at lead 2? If the answer is yes, then we know that the electrical impulse is most likely originating in the SA node. Next, we will measure the PR interval. This represents the time from when the atria depolarizes to when the ventricles depolarize. A normal PR interval is 0.12 to 0.2 seconds, or 3 to 5 small boxes. A prolonged PR interval suggests an electrical delay in getting through the AV node. We will then measure the QRS segment. Here we will see three things. The first is a negative Q wave, followed by a positive R wave, and then a negatively deflected S wave. The duration of the QRS complex should be 0.04 to 0.1 seconds, which is about 1 to 2.5 small boxes. A prolonged QRS segment could be indicative of a bundle branch block or underlying heart disease. Now, depending on which lead you're looking at, the direction of the deflections may be different, but for the purposes of this teaching, we will assume that we are observing lead 2. In the sixth step, we will observe the T wave. Now, the T wave represents ventricular repolarization, or recovery, and this should be positively deflected in lead 2 and should come immediately after the QRS segment. Inverted T waves could be indicative of cardiac ischemia, while tall peak T waves could potentially mean hyperkalemia. Flat T waves may be hypokalemia. And a raised ST segment, which is that ending of the QRS along with the T wave, may be indicative of an ST elevation myocardial infarction, or STEMI. Next, we will look for any ectopic beats. These are beats that originate outside of the SA node. These could be premature atrial contractions, premature junctional contractions, or premature ventricular contractions. If any of these are present, remember to note how many ectopic beats are present and how often they appear. In step 8, we will determine the origin of the rhythm. Here are some key elements to look for. A sinus rhythm will be 60 to 100 beats per minute, regular, upright P waves present before each QRS complex with a normal PR interval and normal QRS duration. An atrial rhythm may be regular or irregular with a normal QRS segment, but P waves may appear differently, either flattened, notched, peaked, inverted, or hidden altogether. A junctional rhythm will have a flat or inverted P wave before the normal QRS segment. A ventricular rhythm may have a wide and strange looking QRS segment and no P waves. Finally, a paced rhythm can be identified by pacer spikes before the QRS complexes. Now in step 9, we can correctly identify the rhythm in front of us. But remember that we don't treat the monitor, we treat our patient. So take what we see on the monitor and consider the patient's complaint along with our OPQRST and sample findings before rushing to your treatment. And finally in step 10, stay current on your ECGs. There are great resources out there to help your ECG skills keep up to date. One of which is the ECG SkillStat, which can display both static and dynamic printouts of numerous ECG rhythms with detailed explanations of each. Another reference point is Life in the Fast Lane's ECG library, which is packed full of easy-to-understand ECG knowledge. So in conclusion, remember that it is important that we take a systematic approach to analyzing our ECGs to ensure that we are not overlooking potential acute cardiac problems. Work through each step and remember to take our ECG findings and consider how the patient is presenting. Lastly, keep up to date on ECG knowledge. As always, stay safe, thank you for what you do, and have a great day.